Hello, anesthesiologists. Thank you again today for all your hard work performing brachial plexus blocks. Bonjour, chers anesthésistes. Merci encore pour tous vos efforts aujourd'hui lors des blocs du plexus brachial. Namaste anesthesia doctoros. ISB brachial plexus block karne mein aapki mehanat ke liye dhanyavad. Right, with that out of the way, let's get straight into it. I am absolutely thrilled to welcome you to this advanced explainer session. We all know how incredibly demanding it is in theater, making split-second decisions about regional anesthesia for shoulder and upper extremity surgeries. Today, we are undertaking a highly rigorous, evidence-based deep dive into the absolute cutting edge of brachial plexus blocks. We are skipping the basics. You already know them. Instead, we're going to critically analyze the latest anatomical insights, cadaveric data, and high-level randomized controlled trials surrounding diaphragm-sparing techniques. This session is designed specifically for you, the advanced practitioner, looking to perfectly balance surgical conditions with maximum patient safety. Here's our roadmap for today. We'll start by unpacking exactly why we are moving away from the traditional interscalene block, tracing the anatomy distally to the superior trunk. Then we'll dive deep into the costoclavicular space, look at hard efficacy data comparing these approaches, touch on infraclavicular and supraclavicular strategies, and finally, bring it all together into a highly practical, diaphragm-sparing clinical algorithm that you can use on your next list. Let's jump in. Section 1. The limits of the interscalene block and the evolution towards the superior trunk. Okay, let's be honest. For decades, the interscalene block has been our absolute gold standard for arthroscopic shoulder surgery. We all look for that classic stoplight sign on the ultrasound to target the C5 and C6 nerve roots. But clinically and anatomically, we have to acknowledge that this proximal location is fundamentally problematic. Why? Because right at the C5 and C6 root level, the protective connective tissue, specifically the epineurium, is incredibly thin. The enveloping fascial layer is literally minimal at best. When you're looking at the screen, it makes discerning the exact neural boundaries notoriously difficult. Because of this lack of a robust connective tissue cushion, your risk of an inadvertent subepineurial injection skyrockets. In fact, if we look at national registry data, the traditional interscalene approach carries a staggering 6 times higher risk of neural damage compared to other peripheral regional techniques. 6 times. A brilliant 2017 letter to the editor in Regional Anesthesia and Pain Medicine hit the nail on the head. They logically argued that targeting a slightly more distal site, where there's actually some fascial protection, is just anatomically and clinically far superior to risking permanent injury at that highly vulnerable root level. So, what happens when we listen to that advice? Tracing your ultrasound probe just a tiny bit distal from those C5 to 6 roots reveals exactly where they coalesce into the superior trunk. It's like watching 2 streams merge into a river. By targeting the plexus after this coalescence, you gain a massive advantage. You can safely capture the suprascapular nerve right where it branches off. Sonographically, the superior trunk gives you a much clearer hyperechoic target. Why? Because it's suddenly surrounded by a much more substantial, well-defined connective tissue sheath. It actually gives you a margin of safety for a perineural injection. And here's a crucial anatomical win. The needle path to reach the superior trunk travels under the deep cervical fascia, which brilliantly bypasses the middle scalene muscle completely. By avoiding the middle scalene, you effectively eliminate the risk of causing needle trauma to the dorsal scapular and long thoracic nerves, which, as we know, run right through that muscle belly. It's a much more elegant approach. And moving this injection site even a few millimeters distally doesn't just protect the nerve architecture, it significantly increases your geometric distance from the phrenic nerve. Let's look at the landmark 2019 anesthesiology RCT. They looked at 78 patients undergoing arthroscopic shoulder surgery using 15 milliliters of 0.5% ropivacaine. The dataset here is just phenomenal. Overall, hemidiaphragmatic paresis, or HDP, dropped from a near-guaranteed 97.5% with the interscalene block down to 76.3% with the superior trunk block. But honestly, the most vital clinical metric for us in theater is the rate of complete paresis. Complete HDP absolutely plummeted from 72.5% with the interscalene down to a mere 5.3% with the superior trunk block. That's a p-value of less than 0.001. Consequently, the preservation of respiratory mechanics is profound. The mean reduction in FEV1 was nearly 45% for the interscalene group, compared to only about 33% for the superior trunk group. So you're maintaining completely equivalent 24-hour postoperative analgesia whilst robustly protecting your patient's lung function. It's a real game changer.
Section 2, Costoclavicular space anatomy. So, what do we do when the superior trunk just isn't distal enough for our most compromised respiratory patients?
This is where we shift our focus to the costoclavicular space. If you look deep to the midpoint of the clavicle, situated precisely between the clavicle and the first rib, the anatomy shifts incredibly favorably for us. The brachial plexus here is essentially boxed in. It's bounded by the pectoralis major and subclavius muscles anteriorly and the serratus anterior posteriorly. And within this very specific space, the three cords, the lateral, medial, and posterior, are beautifully clustered together. They are superficial and positioned directly lateral to the axillary artery. This is a huge distinction. Unlike the more distal infraclavicular approaches where these cords separate and dive all around the artery like a scattered constellation, the costoclavicular space keeps them tightly grouped. You'll see the lateral cords sitting most superficially, followed right behind by the medial and posterior cords. If we take a deeper dive into the anatomical literature, particularly a fantastic 2023 paper in the Medical Science Monitor, the parameters for the costoclavicular block, or CCB, become crystal clear. Because all three cords are visible in a single ultrasound window, guiding your needle is remarkably straightforward. The recommended approach is an in-plane lateral to medial trajectory. Pharmacologically, this clustered anatomy makes your local anesthetic highly efficient. For 0.5% ropivacaine, the ED50 is just 13.5 milliliters, and the ED95 is 18.9 milliliters. Now, microscopic dissections have revealed something fascinating here. There is a distinct connective tissue septum isolating the lateral cord from the other two. This dictates exactly how your local spread will behave, which we'll talk about shortly. And for those of you placing continuous catheters, this location is practically unbeatable. Because the subclavius and pectoralis major essentially lock the catheter in place, dislodgement rates are incredibly low. Compare that to the frustrating historical dislodgement rates of 35% for interscalene catheters and 22% for traditional subclavian approaches. It's night and day. Section 3. Costoclavicular block versus interscalene block efficacy. Let's look at the hard clinical evidence. A brilliant 2025 summary in the Korean Journal of Anesthesiology synthesized 4 major RCTs, and the data is pretty definitive. Let's walk through it. Alistine in 2018 used 20 milliliters of 0.5% levobupivacaine for the CCB, added a superficial cervical plexus block, and demonstrated completely non-inferior postoperative pain scores alongside an astonishing 0% complete hemidiaphragmatic paresis rate. 0. Then Joe in 2022 compared the CCB against the superior chunk block using a 2-injection technique to overcome that septum we just talked about. While early pain scores very slightly favored the superior chunk, opioid consumption was identical and the CCB boasted a markedly lower complete HDP rate, 9.7% compared to 33%. Next, LOA in 2023 looked at a massive cohort of 212 patients under sedation. They did note that suprascapular nerve block success was slightly lower for CCB at 53% versus interscaling 66%, but here's the kicker. Overall surgical success remained totally equivalent, and complete HDP dropped from a terrifying 92.5% down to just 7.5%. Finally, Lee in 2025 looked at different volumes, showing a 5.8% complete HDP rate for CCB against 68.8% for the interscaling group, with absolutely no clinical difference in pain or opioid use. The evidence is overwhelmingly clear. I really want to emphasize the stat, 0 to 7.5%. That is the remarkably low incidence of complete hemidiaphragmatic paresis when delivering a full 20 milliliter volume via a costoclavicular block. How is this anatomically possible? Well, recent cadaveric dye studies have proven that while a 20 milliliter injection in the costoclavicular space does indeed spread cranially, successfully capturing the supraclavicular plexus components, including that vital suprascapular nerve, it maintains just enough distance to largely avoid tracking all the way up onto the phrenic nerve. For your high-risk patients on the list, those with severe COPD, asthma, or morbid obesity, this is an absolutely monumental safety advantage. But here is an essential clinical pearl for both our registrars in training and our seasoned consultants. If you are using the costoclavicular block as the sole surgical anesthetic for a shoulder procedure, you absolutely unequivocally must supplement it with a superficial cervical plexus block. Remember the anatomy. The CCB purely targets the brachial plexus cords. It will completely miss the cutaneous branches that originate higher up from the cervical plexus. This means the superficial cape distribution of the shoulder, the skin where the surgeon is actually cutting, will be completely unanesthetized. Adding a simple, fast, low-volume superficial cervical block ensures complete cutaneous coverage so your patient remains perfectly comfortable. Do not forget this step. Section 4. Moving further down the arm. The infraclavicular versus costoclavicular approach. So what about surgeries of the elbow, forearm, and hand? We need to evaluate the newer costoclavicular block against the traditional lateral paracoracoid infraclavicular block. A very robust 2024 meta-analysis encompassing 5 RCTs and nearly 400 patients tackled this exactly. The clinical outcomes, meaning sensory and motor onset times, as well as the time it took to actually perform the block, showed no statistically significant differences. The exact failure rates were 6.7% for the CCB versus 3.8% for the traditional infraclavicular approach. Again, no statistical significance. Overall complication rates were remarkably matched at roughly 2.1% for both. However, we do know from the literature that when using larger volumes, say 35 milliliters, the traditional infraclavicular block's HTP rate can occasionally spike up to 9%. But what really sets the CCB apart for daily practice is its theoretical ergonomic superiority. Visually seeing all 3 clustered cords in one single superficial ultrasound window requires far less needle manipulation than hunting for separated cords diving around an artery. And quite remarkably, a sensitivity analysis within that same meta-analysis revealed that if they excluded one specific outlier study from 2020, the CCB actually trended toward a significantly faster sensory onset.
Section 5. Supraclavicular injection strategies, specifically for complex vascular cases.
Creating an arteriovenous fistula in end-stage renal disease patients presents highly unique challenges. These patients often can't tolerate general anesthesia, requiring precise, reliable supraclavicular blocks. A pivotal 2014 RCT in anesthesia and analgesia compared single versus triple injection techniques in 96 renal patients. The findings? The triple injection technique yielded a 20 to 31% higher composite sensory block success rate at the crucial early time points, 10, 15, and 20 minutes. It also provided significantly superior coverage of the musculocutaneous nerve, which, as we all know, is notoriously easy to miss. The anatomical reason for this goes back to what we discussed earlier. The connective tissue septum compartmentalizes the plexus, mechanically restricting the spread of a single large bolus. Now, the trade-off is obvious. A triple injection takes significantly longer to perform, with a p-value of 0.001. Adverse events were extremely low across the board, though Horner syndrome did occur slightly more in the triple injection group. But here is the most practical takeaway. Ultimately, by the 30-minute mark, both techniques achieved equal rates of surgical anesthesia. So think about your workflow. If your vascular surgeon is scrubbing in and rushing you, utilize a multiple injection technique to overcome that septum quickly. But if you have 30 minutes of prep time while the patient is being positioned, a single injection is perfectly adequate.
Section 6. The diaphragm-sparing clinical algorithm. This is where we translate all this dense data into a definitive decision matrix for your clinical practice.
First, we must objectively evaluate our block choices strictly against HTP incidence. Look at this table. A standard 15 to 20 milliliter interscalene block basically guarantees 97 to 100% paresis. Even attempting a low-dose 5 milliliter interscalene block still results in an unacceptable 27 to 45% paresis rate whilst drastically compromising your analgesic duration, so that's practically useless. Moving distally to a 15 milliliter superior trunk block drops complete paresis down to just 5%, which is excellent. And both the posterolateral supraclavicular and costoclavicular blocks, even with generous 20 milliliter volumes, reliably keep paresis rates firmly below 10%. Now, as a brief academic aside, the literature does discuss a highly targeted, very low-volume 4.2 milliliter anterior suprascapular nerve block as a theoretically perfect diaphragm-sparing alternative. But realistically, it currently lacks the robust, large-scale clinical validation of the CCB or STB, so we aren't relying on it as a primary surgical strategy just yet. So based on all the trials we've covered, here is your definitive, evidence-based algorithm. Step 1. For a standard arthroscopic shoulder surgery in a healthy patient with completely normal lung function, the traditional interscalene block absolutely remains the most reliable, dense analgesic technique. Step 2. For patients presenting with mild respiratory impairment, shift your probe distally. Perform a superior trunk block, ensuring you target the plexus post-coalescence to successfully capture that suprascapular nerve. Step 3. For patients with moderate to severe respiratory impairment, severe COPD, or morbid obesity, bypass the neck entirely. It's just not worth the risk. Opt for the Costoclavicular Block. And remember to supplement it with that superficial cervical plexus block for the cape distribution. For distal upper extremity surgeries, from the elbow down, both the CCB and the traditional infraclavicular block are your solid, evidence-based standards. And finally, for those tricky AVF surgeries, rely on the supraclavicular or CCB approaches, deploying multiple injections if you need rapid onset. I'm going to conclude this deep dive with a critical, slightly provocative question for our specialty. We have spent this entire session discussing these highly advanced diaphragm-sparing techniques. But how accurately are we actually identifying the patients who truly need them? Are we still relying solely on a subjective clinical history and a quick pre-op chat? Or are we actively incorporating routine hemodiaphragmatic ultrasound right there in the holding bay? To truly elevate our practice as modern anesthesiologists, we must objectively measure baseline sonographic parameters. Are you actively assessing diaphragmatic excursion? Are you calculating the diaphragmatic thickness ratio before you formulate your regional anesthetic plan? By integrating precise point-of-care ultrasound diagnostics with these advanced regional techniques we've discussed today, we can deliver unparalleled, targeted, and rigorously safe analgesia for every single patient on our list. Thank you so much for joining me, and I hope this transforms your approach in theater tomorrow.